Hi guys, um, this is Dr. T and welcome to Clinical Medicine. So guys, this is our second video of the day. So the first video, we did discuss our anesthetic approach to that patient who had an epidural hematoma. So the patient that we're gonna be doing now is an obstetrics patient. So we did a GA for this patient. So most long questions in anesthesia, they come in the form of scenario. They give you a scenario, they tell you what is wrong with the patient, and they ask you what's the approach. That's why I'm gonna be doing a lot of these in the coming few days. So this patient we saw when I was on call yesterday. So we did a couple of GAs yesterday in the obstetric theater. So this patient, 18-year-old, so she was a primigravida. She was a primigravida at 31 weeks. And the reason why she had to be delivered is because she had eclampsia. She had eclampsia. So now when we saw her, obviously it's an emergency, so we didn't go and do a pre-op in the ward, pre-op assessment. But before the patient came into theater, it's a standard procedure that we go when the nurses are receiving the patient from the labor ward nurses. So when the theater staff is receiving the patient from the labor ward nurses, we go through the file, make sure that the consent is there, we make sure that the patient understands why they need to be operated, and we look at the bloods and we tell them that okay, we are the anesthetic team and this is what we're going to be doing, and just to make the patient to be aware, because by that time they've already signed the consent, so they know exactly what is going to happen. So now when you've got a patient like this, I think there was also fetal distress as well. There's fetal distress, but the main reason for delivering the patient, these two so these indications, even if they were isolated, the patient will still need to be delivered. Fetal distress is a condition to deliver the patient. Obviously you're gonna look at what's the cause and all that and what weeks is the patient, but fetal distress, most of the time you're gonna send that patient to, you're gonna deliver that patient. Obviously an eclamptic patient needs to be delivered. So now most of the times, as we all know, spinal is the preferred mode of anesthesia for the pregnant because of a lot of reasons, which I'm not going to talk about. Maybe I'll do a video on that. So most of the times we do give a spinal, but the problem with this patient is that she had eclampsia with a low GCS. She had a low GCS. When you've got a patient with a low GCS, it means that it's gonna be hard for you to actually, because she was this patient was like an on and off kind of. So I think she had a bit of confusion. That was just like very mild. She was coming into and out of confusion because there were moments she would talk sense and then the next minute. So because of that, you're like, will she really cooperate with the spinal? Because with the spinal, you're gonna need someone who's gonna sit there and actually help you, make it easy for you to give them the spinal. They'll be seated or lying on the side and things like that. So you need someone who's gonna cooperate, basically there. So we didn't trust that she would cooperate. So we opted for a GA. So what did we do? Obviously, the patient came in. So first thing, attach monitors. NIBP. Sets probe. CG. And then so we already decided that we're gonna give a GA and alpha, so we already had the drugs because we were told about her even before she came. Sure. So the drugs already prepared. So IV line. She had a good IV line, so we didn't have to insert an IV line. She already had one. So the third thing, so now after everything has been prepared, everyone is calm now, we've got everything that we need. So this patient was given so you know when you are good with when you are very observant, when there's a deviation from the normal, you can quickly pick it up that okay, why are we using this, why are we doing this today, because most times we do this. So I had to ask my doctor after this case that why did we give magnesium sulfate. So when you remember what I was explaining in the other video, that okay, when you are gonna give your anesthetic approach, the first thing that you must ask yourself is this an emergency or is it an elective? That's the first question. So emergency or elective? So if it's an emergency, you're gonna do a rapid sequence induction. If it's an elective, you're gonna do a normal sequence, right? Now this patient was an emergency. Eclampsia is an emergency, so we had to do a rapid sequence for her. So okay, let me just finish. I wanna go back to this. I wanna come back to this. So attach, guys, I'm tired. it's like, what time is it now? 20 past 10, and I was on call yesterday, so I'm very tired. So attach monitors, IV line, magnesium sulfate, cricot pressure, propofol, saxmethonia, wait for 30 seconds, insert ET tube, 8, confirm, placement, 9, after confirming placement you secure, 10, connect the PT to the vent machine. Okay, so guys, this is a rapid sequence. Please watch the first video where I did an elective sequence or a normal sequence, and you will see the difference. For that patient, the neurosurgery patient, it was an elective, so we did a normal sequence. With this one, we did a rapid sequence. So the difference, there's cricoid pressure in this patient, right? And we also gave saxmethonium in this patient. So please go and look at the steps and check them. So this patient, and compare, because if you can understand that and this, then now you're gonna have a good base going forward. So this patient was maintained on isoflurane until the operation was done. So now what I wanted to come back to is this guy. You know, for the first time I got to know that you can give magnesium sulfate to blunt intubation response, because I did ask my senior. So now this thing takes me back to a question that we once got in medical school. They asked us about the 4 uses of magnesium sulfate in theater. It was a very unfair question, I think. Anyway, so blunting of intubation response. Remember, we have spoken about this. The drugs of choice, now that we know that you can use magnesium sulfate, and the reason why he said we can use magnesium sulfate is because this patient was already loaded with magnesium sulfate already, because she was eclamptic, so we needed just lower doses now of magnesium sulfate. So we already have a drug that was already in the system already, so it was just a matter of just topping it up. And yeah, so magnesium sulfate, these are the options for blunting intubation response. And there's a video where I speak about what intubation response is, and I speak about these drugs, but I didn't mention this. But now, just to refresh, so so you can use magnesium sulfate, you can use fentanyl, you can use lignocaine. Remember, lignocaine, there's an IV lignocaine and then there's an IM lignocaine. So you have to give the IV lignocaine. So you can also use the spray. What else? I think I'm forgetting about 2 drugs there that can be used to blunt intubation response. Forgetting that now. Okay, fine. And please go and watch a video where I do a drawing and explain exactly what is cricoid pressure, how do you do it, how do you locate it, the cricoid, and what's the idea behind it, or what are the mechanics behind it. Yeah, so now, what were the other drugs that this patient got? Remember, as long as you are the anesthetist, you are the one who give the drugs. It's not the surgeon. So we gave an antibiotic, cefazolin, prophylactic antibiotic, cefazolin. We gave manzolone as an antiemetic together with dexamethasone. We also gave morphine for pain. We also gave what else did we give? We gave obviously syntocinon or oxytocin, which is just to make sure that the patient doesn't develop postpartum hemorrhage, to make sure that that uterus stiffens up and occlude those vessels. So this lady delivered a live male baby with good AVGAs. So that's that, guys. So the important thing here is that we used, because it was an emergency, so we did a rapid sequence. And the differences between rapid sequence and elective sequence is these things: the sacs that is used, the cricoid pressure, and then pay attention to the reason why we opted for a GA instead of a spinal. It was this low GCS. An eclamptic patient that comes in but is no longer fitting, maybe the seizures were aborted, comes in with a GCS of 15, we can still do a spinal provided the platelets are normal. Provided the platelets are normal, or say, some people would say as long as they are more than 50, some would say as long as they are more than 100, some say even more than 75. So there's just different things out there. So when in an exam they tell you a story of a patient who's pregnant, who needs to go for delivery, read the scenario very well with the mindset that, okay, a pregnant woman, most of the times they do a spinal, but the one that I'm reading now, the scenario that I'm reading now, what will make me to say it's gonna be a J, not a spinal? So look for the things that will make you to say, okay, I know that most of the times we do a spinal on a gravid patient who needs to deliver, but now I'm gonna read this scenario and the question and make sure that I understand. If I have to say I will do a spinal, what would make me to say that? You see? So a patient who's got a fetal distress, that's not an indication for a spinal. A patient who's got eclampsia, it's not an indication for a spinal, as long as they've got a good Jesus of 15. So, but if they say a patient is pregnant, needs to go for a C-section, and the platelets are low or whatever, also there you want to run away from a spinal and do a GA on that patient. So make sure that you look at the question and I hope that, guys, this will help. So we're gonna keep doing this. Tomorrow I'm going to an orthopedic theater. I'll bring you 1 or 2 cases from there as well, just to appreciate the differences between this. And I think that's what I'm saying, I would have loved to be taught anesthesia this way. Yes, like I would have loved, on top of what I've been taught, I would have also loved to have a component like this. Unfortunately, we didn't have it, and they asked it. Because remember, you are a student, you go to theater, and you are just standing there, you are watching. And in theater, as a student, it's very intimidating because you don't know what to touch. You don't know what to touch because you don't want to make mistakes. You don't want to be shouted at because it is a critical area, and all of that. So now, if they're gonna ask you, I mean, this, for you to know this, you must have been in theater. For you to know this sequence, you must have been in theater. You must have seen it. You must have done it yourself as well. So I hope you guys, you will appreciate this. Thanks.